So if we could go for the first presenter, please.
Okay. Hello, so my name's Julian Cumberworth. I'm a CT2 in anaesthetics, and I'm currently working in Brighton, but last year was East Sussex Healthcare NHS Trust, which is where I completed this project. So this is a quality improvement project where we looked at knowledge of trainees, the locations of certain anaesthetic emergency drugs within our theatre complex. So to give a bit of background on this topic, as I'm sure many people aware,
okay, I'm just going to pause. I'm just going to pause things for a
second. Immediately available. There are some slightly less commonly used drugs.
Hello.
Which are not drawn up.
Hello. Can you hear me? There you go. I'm just going to pause things for a second because we've got a very bad internet signal. I'm going to ask. Have we lost our presenter? Maybe. There was a very poor internet signal. So if we get our presenter back, then what we'll do is that we'll ask everyone to turn their cameras off as well, which gives it a better chance of getting a good signal through. Have we got them back? Not at the moment, it would appear. Julian, there we go. How are you doing, Julian?
Hi. Apologies. I think my internet connection was interrupted.
Yes. So what we're all going to turn our videos and mute for you, Julian, to give you the best possible chance. Is that okay?
Yeah,
so
that's
we'll do
fine.
this is starting all over again. So good luck. There we go.
Okay.
We'll turn off it. This usually settles things down. Off you go.
Okay. So my name's Julian Cumberworth. I'm a CT2 anaesthetics trainee, and I'm currently working at Royal Sussex County Hospital in Brighton, but was previously East Sussex Healthcare NHS Trust, where I completed this project. As many of you, or most of you, will be familiar, there are commonly used anaesthetic emergency drugs which are routinely drawn up at the start of operating lists as a matter of course. There are slightly less commonly used drugs which are not routinely drawn up, but it's considered crucial to know the locations of within the operating theatre complex. And this has been highlighted by the Royal College of Anaesthetists in a number of documents. I've included a couple of lines here from a 2016 document, which effectively says that they should be stored in a central location, serving the entire theatre suite. We thought that it'd be interesting to work out or to look into how well known the locations of these drugs were amongst us and some of our colleagues, and then inform people of the locations, and then sort of reassess that, particularly in the context of changing operating theatre practices and sort of operating procedures throughout the period of COVID-19. So the way in which we did this was by putting together a simple questionnaire. We chose the drugs as dantrolene, sugammadex, intralipid, and adrenaline at the 1 in 10,000 dose for cardiac arrest. It was a relatively simple questionnaire. We effectively asked people their grade of training or their seniority. We asked them whether they knew the locations of those drugs. And after that, we provided them with some information which we put together with the help of ODPs on the location specifically of those drugs. And that was after, as I mentioned, some reconfiguration of theatres. So that gave us some quite interesting results. There was quite a bit of variability, as you might expect, in the knowledge that people had of those drugs. We had with us at that time some foundation trainees who hadn't done much anaesthetics, so their knowledge was understandably slightly less significant at that time. And the more senior doctors, as you might expect, had a greater sort of general knowledge of where those drugs were stored. But there was some variability at every level, as you can see in the results table there. Some people had a complete knowledge, whereas some people had a few gaps around some drugs, particularly dantrolene and intralipid. So after that, we reassessed all of the original participants sometime later. We tried to have a general cross-section of the trainee body. So as you can see, we had some core trainees, some foundation trainees, quite a few registrars, and then one specialty doctor as well. And we effectively re-questioned all of those individuals again. And unsurprisingly, everybody after that relatively simple intervention, knew where those drugs were stored. I think that's probably slightly easier because we just focused on 4 key drugs, and also sort of went around theatres and showed people as well, which presumably helped. So I think to conclude, as I said, unsurprisingly, the more senior clinicians had a better idea of where the drugs were stored, but it wasn't complete. And clearly, when you do need these drugs, it's likely to be in an emergency situation where you need to be immediately able to lay your hands on them. So it was quite useful to find out that that not everyone did know where those drugs were stored, and to sort of help us cohort to improve our knowledge of those. And I think the next step would be to do maybe a slightly larger study over time, working with some of the other theatre staff who we might call upon to help us with administering and locating those drugs, such as our anaesthetic nurses, ODPs, and some of the more senior anaesthetists. So thank you very much for listening to my presentation.
Well done, Julian. Thank you very much indeed. Next up is Megan. Everyone can try turning their cameras back on if they wish. We'll see how Megan's signal does. Hi, Megan.
Hello, hi. I'm Megan. I'm a core anaesthetic trainee in London, and this is a project I did earlier this year with Dr. Sim West at University College London Hospital, looking at spinal dosing in hip fracture surgery. So the background to this project is that lower doses of anaesthetic in hip fracture surgery may be associated with reduced levels of hypotension and better outcomes. And our hip fracture protocol at UCLH suggests using lower dose spinal anaesthetics for hip fracture surgery. So we recommend under 2 mils of heavy bupivacaine. You can see that in the first image on the poster. However, first we wanted to see if we're following this protocol. And also we noticed that many of our colleagues had concerns about using this dose of spinal anaesthetic, including whether or not it will last long enough for the duration of the surgery. So we also looked at that. We also looked at the duration of hypotension with each of the types of anaesthetic. So methods, I looked at data from the National Hip Fracture Database from January to May this year and identified all of the patients who had surgery for hip fractures. We then looked at the electronic anaesthetic charts for each of these patients. And we're very lucky at UCLH to have EPIC, so it's all electronic, so it's very easy to get this data collection. So using EPIC, we managed to look at the dose of spinal anaesthetic given, quite accurately at the duration of anaesthetic time and surgical time combined. And then also quite accurately look at the hypotension, because the blood pressure is automatically entered onto EPIC from the monitoring. So there's no editing of the blood pressure values. So we looked at all of those 3 things. Results, we found 47 patients in this time period, which is less than normal, obviously due to COVID. And you can see in figure 1, each of the different types of anaesthetic given for our hip fracture patients. So our protocol is not being followed, it's the first thing to say. Most of the patients received a higher dose spinal anaesthetic, which we classified as being over 10 milligrams of heavy bupivacaine, so over 2 mils. Around a quarter of them received a general anaesthetic, and just 20% were following our guideline of a lower dose spinal anaesthetic. Secondly, we looked at the duration of the procedure. So in figure 2, we've got the duration from the time of spinal injection or from the time of induction to the end of procedure. And the spinal dose groups were about the same duration, and GA slightly longer, which was to be expected because we'd use a GA for expected prolonged surgery. So reassuringly, none of the spinal anaesthetics needed a conversion to GA, including all of the low dose spinal anaesthetics. So that was reassuring data to present to our colleagues at UCLH. We also in figure 3 looked at the duration of intraoperative hypotension, and you can see a much shorter duration of intraoperative hypotension for the lower dose spinal anaesthetics. That might be confounded by the fact that the people that are doing the lower dose spinal anaesthesia may also have a greater awareness of the effect of hypotension and our current hip fracture guidelines. So to summarize, we're not following our hip fracture protocol at UCLH, so this can be presented locally and ongoing audit. The lower dose spinals were all sufficient for the duration of surgery in this audit, and also were associated with lower durations of intraoperative hypotension. But these are just small numbers, so further research is needed to look at the outcomes for lower dose spinals in hip fracture surgery. Thank you very much for listening.
Megan, thank you very much. Next up is Ola.
Yes, Hey, how are you? So, my name is Ola Nordrum. I'm the current anaesthetic intern in Galway University Hospital. And this audit looked at the CO2 equivalent of emissions from anaesthetic gases in Galway University Hospital, which is considered a large Irish university hospital. So obviously, with the current kind of focus on sustainable healthcare and the focus on the carbon emissions from healthcare, we wanted to look at the carbon emissions from anaesthetic gases over a year. I suppose nice numbers to kind of look at is that within any country, roughly 5% of CO2 emissions is from healthcare itself, and within healthcare, roughly it's alone. There's not 100% accurate statistics, but they're kind of nice numbers, so 5% and 5% again. So we wanted to break those numbers down and look at the CO2 emissions from anaesthetics, and then come up with a baseline and a number where you can work from and look to decrease emissions. So basically what we did, we looked at anaesthetic gas use over 1 year, 2019, in Galway University Hospital, and then we calculated the CO2 equivalents of the different gases. You can see down the left corner, sevoflurane is 130, CO2 equivalents, nitrous oxide is 298, isoflurane is 510, and then desflurane is 2,540. So you can see that the fluorine is a very potent greenhouse gas. The same goes for isoflurane, nitrous oxide and sevoflurane, less so. But the problem with nitrous oxide is the amount used. So then we can shift to the middle. You can see here that over 1 year, the department in Galway produced 922 tons CO2 from anaesthetic gases alone. And this equates to roughly 54 tons per anaesthetic machine. And of this, 91% came from nitrous oxide and desflurane. And you can see here in desflurane was responsible for 16% and nitrous oxide responsible for 76%. So you can think that these would be kind of easy pickings if you were to try and decrease the carbon emissions from the anaesthetic department. And if we try and look at these numbers in kind of more day-to-day terms, 922 tons of CO2 is roughly equivalent to what's emitted from 200 passenger vehicles a year. But we also require 185 hectares of Irish forest to sequester, so it is quite the significant emissions. And we truly believe that awareness around this, that an anaesthetic department do emit quite a significant amount of CO2 from anaesthetic gases is an important fact that any department needs to be aware of going forward towards more sustainable healthcare and trying to lower their emissions. So that's me. Thank you.
Thank you, Ola. We'll see you back again soon. Thank you.
Yep.
So, Robert.
Hello everyone, my name is Robert Lee. I'm a Senior House Officer in University Hospital Galway in the Department of Anaesthesia. I'm here to present an audit that myself and some colleagues performed on our use of antimicrobials in routine prophylaxis for our surgical patients. So with this audit, we wanted to review our usage of antimicrobials in this setting with respect to antimicrobial stewardship as it pertains to the local guideline which was developed by the Department of Microbiology, Infectious Disease and Pharmacy. Like many hospitals in Ireland, we use a mobile app to distribute this guideline. And I suppose the importance of this audit lies in the fact that infections are becoming more difficult to treat now with the rise of multi-drug resistant organisms. But also we wanted to ensure that patients are being exposed to the agent most likely to offer them benefit, as these are not benign agents and they also have the potential to do harm as well as treat disease. So in assessing our adherence with this guideline, we compared the usage of antimicrobials as recorded in the anaesthetic chart with the Antimicrobial Policy app in GUH. Other considerations such as allergies, other infective concerns around the patient, or issues that would make the case outside the scope of such guidelines was also taken into account. And so based on that, of 35 cases that we audited, 6 were excluded. Reassuringly, 63% of cases that we reviewed were in line with the guidelines, whereas 47 were not, beg your pardon, 63% were in line with the guideline, and 37 were not. So that is quite a reassuring statistic. While it is concerning that comoxiclav, gentamicin, and cefuroxime, quite broad spectrum agents, were at the forefront of those that were being inappropriately used. In order to address that, I intend to present these findings to the department and make everyone aware that, you know, perhaps we need to be more mindful of the guideline rather than doing what we're familiar with. We need to ensure that what we're doing is based in evidence, and that what we're doing is most likely to offer the patient benefit, and not only the patient in front of us, but all the patients down the line who require treatment made complicated in a post-antibiotic era. And we will re-audit at that point and see how we're doing. Thank you very much.
Thank you, Robert. Michael's up next.
Okay, hi, hello everybody. My name is Michael Ma. I'm a anaesthetic fellow in the queue at the moment, but this presentation, this case study was performed in the Royal Victoria Ioneer Hospital at the time, and it's entitled Anaesthetic Management of a Patient with Lyme Disease and Familial Hypercalciuric Hypercalcaemia.
Michael, Michael,
yes.
sorry to interrupt for a second. You're slightly out, slightly out of camera. So you.
Okay, sorry. Hold tight.
That's okay.
Let me just see. Sorry, apologize. That will that work? Okay. Sorry, I wasn't actually looking myself at the same time.
We're okay with you being out of camera, but you might not like the final result. So
no, that's fine. That's perfect. Okay, very good. Is that better?
Yeah, good man.
Okay,
off you go.
So,
go, Michael, can you go from the top again? Because we'll edit that.
Yeah, no worries. Like I said, anaesthetic fellow, and we did this case in the Ioneer, the Royal Victoria Ioneer Hospital in Dublin, Ireland, and the presentation is entitled Anaesthetic Management of a Patient with Lyme Disease and Familial Hypercalciuric Hypercalcaemia. So, Lyme disease is an underreported and multi-system disease, and is the world's fastest growing vector-borne infection, and cardiac and neurological symptoms are most pertinent in anesthetic patients. Thorough preoperative evaluation of these patients is essential, especially when coexisting with other comorbidities. As such, in this case, a patient with all, concurrent familial hypercalciuric hypercalcaemia. So this was an 18-year-old female presenting for preoperative assessment for tonsillectomy with background of chronic Lyme disease and FHH, chronic fatigue, myalgia, and constipation. Her medications included naltrexone and Mimpera and a few multivitamins as well. She was investigated a month ago for non-specific chest and abdominal pain with calcium levels that were above 3 millimoles per liter, and discharged with endocrinology follow-up at that stage. Preoperatively, cardiovascular and neurological exams were normal, and in light of her Lyme disease, a 12-lead ECG and echocardiogram were scheduled to evaluate her ventricular function and outrule any pericarditis or pericardial effusion. Both investigations were normal. She was admitted the night before surgery for observations, prehydration, and repeat bloods, and was scheduled first on the list as well. The day before her surgery, her adjusted calcium level was 2.95. She was prehydrated again with maintenance of normal saline. The calcium levels of the day of surgery corrected to 2.45 millimoles per liter, and levels were monitored intraoperatively and remained normal postoperatively. Despite holding her naltrexone, she required repeated opioid boluses for breakthrough pain, and she was comfortable before leaving recovery. She was discharged a day later and advised to keep her endocrinology appointment, and patient was consented for was obtained as well. So just key messages for this case. A thorough preoperative assessment and perioperative plan is essential when patients present with either Lyme disease or hypercalcemia. And cardiac and neurological involvement are primary concern in those patients with Lyme disease, but also can be of importance for those with hypercalcemia as well. One must be vigilant of the sequelae of hypercalcemia and ensure prompt and adequate management, i.e. hydration, and preoperatively to prevent potential clinical deterioration. And that concludes my case study.
Well done, Michael. Thank you very much. Next up is Venkat.
Thank you.
Thank you, Michael. Venkat? Have we lost you? So Venkat, I don't know if you can, you might be muted, Venkat, but you're out of camera at the moment. Venkat, can you hear us? I know you were in the operating room, I think. So what we're going to do is we'll come back to you, Venkat, if you show yourself, but we're going to jump ahead to the next poster, which is back to Megan. So Megan, if you're there, if you could jump in, that would be great. Thank you.
Hi, I'm Megan. I'm a core anaesthetic trainee in London, and this is a project I'm doing with Dr. Manaz Khan, who's the pre-assessment anaesthetic consultant lead for the Whittington Hospital in London. And this is looking at preoperative cognitive impairment and screening and management of it. So this is important because up to 50% of patients over 65 might have some degree of cognitive impairment. And the recent Royal College of Anaesthetists Raising the Standards booklet suggests that firstly, all older surgical patients over 65 should be screened for preoperative cognitive impairment. And secondly, they should be placed on a pathway if they're found to be at high risk. So we have recently introduced screening in our pre-assessment clinic using the MiniCog screening test tool. And the MiniCog is a well-validated screening tool for dementia, which has a similar specificity and sensitivity to the MMSE. And you can see in the first picture there, this is the MiniCog screening tool. It involves memorizing 3 words and drawing a clock face. And the scoring system is shown there at the bottom right as well. So first of all, we looked at our patients presenting to pre-assessment between August and September to identify, firstly, the number of MiniCog screening tools carried out, and also how many of the patients were positive, and therefore that would help us create our pathway for these patients. So between August and September, we had 29 patients over 65 presenting to our pre-assessment clinic, which again is slightly altered numbers compared to usual because of COVID. And 8 of these patients had a positive MiniCog screening score. So that's about a quarter of our patients over 65 presenting to pre-assessment with no previous history of cognitive impairment were positive on the MiniCog. And you can see there's some examples of the clock faces that we were faced with in our pre-assessment clinic. And this has obviously multiple implications for the perioperative period in terms of preoperative and postoperative complications and also consent. So the first things that we do with our pathway is create a highlight on the operative lists for theatre so that everyone knows that the patient has cognitive impairment. And the second thing is to highlight to the surgeons the results of this screening tool so that they can make sure the patient has appropriate consent, which may include calling the next of kin or getting an IMCA. And this is really relevant because we've had at least 2 cases in the last month where patients have presented on the day of surgery with cognitive impairment that has not been picked up, and they have had the incorrect consent forms, which has caused delays and also has implications for patient safety. After that, we'll hope to liaise with the geriatricians, and ideally all of these patients would have a comprehensive geriatric assessment. And this is why this audit is useful, to give us an idea of the number of patients and the workload that might add for the geriatricians. Other things in the pathway will include anaesthetic management. So for example, avoiding certain medications, using regional anaesthesia, depth of anaesthesia monitoring, and also screening the patients post-operatively for post-op delirium because they'll be at high risk for that. So in summary, preoperative cognitive impairment is important and it's prevalent, and we should screen for it. And we should then create pathways for these patients. And we found that the MiniCog screening tool is easy to use and and is useful for us in our trust. Thank you very much.
Megan, thank you very much indeed. Now, I think Venkat has back to us. Is that, am I correct there, Venkat? Are you able to present? I'm going to see if I can get back to your poster. Welcome back. Can you hear us okay? You might be muted.
Yes. Hi, everyone. My name is Venkat. I'm one of the registrars at Northeast Hospital in Stockton. So the reason that this audit was done, because we had almost a drug error. So it was about a lady who came in for an emergency C-section overnight, and during the handover, we were not quite pragmatic in approaching the handover, and she almost had 2 doses of antibiotics within a short span of time. So thankfully, the patient didn't come to any harm, but we realized that something could have happened if there was a communication gap, and we realized that there was a lot of room for error in the handover. So we thought we'll go back and check what could have been done, what could be done in the future. So that's the reason for this audit. So the purpose of the audit was to, identify the communication gap and, to see if we adhere to the handover policies that the hospital had. So the standard is like all the emergency obstetric procedures should be predated by appropriate and a documented SBAR handover. So it was a prospective single center study at Darlington Memorial Hospital. We did it for about 15 days. In the 15 days, we had about 40 patients who had emergency obstetric surgery. So, and we noted that in only about 18 of the patients, there was a documented SBAR handover. So we thought what could be done to improve the adherence to the policy. So we thought we'll introduce a handover tool, which, as you can see on this chart, which would contain what is the communication and what is the indication for the anaesthetic referral, and what is the key concern in the for the patient needing the anaesthetic. And we also wanted to know what could be the temperature and the heart rate in the last reading before coming on to theaters, because we noted that sometimes the patient have a high degree of high temperature, and the patient either had peripartum sepsis, so which sometimes goes missing. And we also wanted to know what medications she's had in the past and what medications she's on, and what is the BMI, and if she's got any allergies, and has she got any group inside. So I do understand that we have all of these as a routine part of handover, but if we have a structured like a label which goes on to the patient's notes, it would be easier for both the obstetric team and the anaesthetic team to just go through it in under a minute, which would make things a bit more slick and safe for the patient. So so in conclusion, like our hospital, we did not adhere to the standard SBAR handover policy. We will introduce a handover tool to improve the adherence to the policy, and we plan to re-audit in about 6 months' time to make sure that we still do adhere to the policy. And thank you. Thanks for listening.
Thank you, Venkat. So now we have Ola back for a second presentation.
Yes, hello. So my name is Ola Nordrum again, and I'm the anaesthetic intern in Galway University Hospital. So this audit looked into medication storage and availability in the anaesthetic drug trolleys.
We have lost Ola for a second.
Galway University audit, quite significant statistics surrounding.
Oh, Ola, we lost you there for a second. So we're going to ask everyone to turn their videos off. And if you want to start again, we'll edit that bit out. Okay. You stay in video, Ola.
Yeah.
There we go. Give it another go from the beginning.
Yeah. So my name is Ola Nordrum. I'm the anaesthetic intern at Galway University Hospital. And this audit looked into medication storage and availability in the anaesthetic drug trolley at a single institution. And the background for this audit lies in the quite significant statistics surrounding drug errors, and showing that in 5.3% of surgeries there is a drug error, and 70% of these are preventable. So in 2017, the BJA published guidelines outlining initiatives and actions that could be taken to decrease chance of drug errors. And among these ideas or suggestions was standardizing the medication storage in the drug trolleys. So that drug A will always be found in drawer 1 across all drug trolleys, and drug B will always be found in drawer 2 across all the anaesthetic drug trolleys at that institution, thereby decreasing the chance that you grab the wrong drug by accident. And it also would make your work more efficient, as you would always know where the drug is. So the methodology, we audited 18 drug trolleys across Galway University Hospital in a 24-hour period. Most of the trolleys were audited in the evening, and we audited the positioning of all the drugs across the drawers in the drug trolleys, and we also audited the different concentrations to see if there were any discrepancies in terms of differing concentrations across the trolleys. And the results were quite shocking in the sense that only 4 medications out of 47 were consistently found in the same drawer or the same position across all the drug trolleys, meaning that 43 drugs were not consistently found in one drawer. That does not mean that the drugs weren't found in the trolley, but they were not found in the same position. And I suppose notable medications that we found not to be consistent was salbutamol, 17% consistency, noradrenaline, naloxone, and also metaraminol. And an additional finding that we observed was that in 45% of the
We've lost you a second for a
trolleys
second.
was in the foreign language, as is.
Oh, no, we lost you for a second. Just back up a little bit. We'll edit it for you.
Yeah. Okay. So back up to the results then.
Yeah.
So we, in terms of the results, we found that only 4 medications out of 47 were consistently found in the same drawer of each cart. That is not to say that the drugs weren't found in the trolleys, but they were not found in the same drawer or the same position in all the trolleys. And notable medications then would be salbutamol, that was only found consistently in one position in 17% of the trolleys. Noradrenaline was the same, and also naloxone and metaraminol were only found consistently in 78 and 67% of the trolleys. And I suppose unexpectedly, we also found that in 45% of the trolleys, medication with entirely non-English branding was found, and namely Spanish and Italian, and also a few in German. And these medications only had an English label stating the name and the concentration of the medication, but nothing else was in English. In addition, we also found that a few medications were incorrectly placed in the trolleys altogether. So rocuronium was found in 25% of trolleys, and this is a drug that obviously should not be placed in a medication trolley. So in conclusion then, maintaining consistency in the medication and medication availability and standardizing concentration is a key initiative to reduce the chance of drug error and ensure the safety of patients under our care. Yeah, thank you.